sounds on there. Yeah, and they are suggestive. A split S1 is not typically considered normal, right? But if you do find it, so you want to make sure that you notice that, right? And S2, if you do find a splitting of it, usually occurs with, when they're breathing. So change. You want to listen to them inhale and exhale. A lot of times when you listen to heart sounds, you prefer them not to be doing either of the two. So you might ask them just to not breathe for a second. So this is the reason you supposedly hear this. Remember we did it, give me the top of the S3. Okay, that was good, right? So that's considered the vibration from ventricular filling, creating an extra sound on there. So it would be pretty forceful, right? To be able to create that. And then that's the reasons, right? In states of fluid overload, it would be very forceful to hear that sound on the ventricle. And S4, give me a sound of how an S4 might sound. So that was like S3, right?
Sorry.
You know what? No, that's okay. I know the pressure's going. You're doing good. I appreciate. I was wondering if that's not good. Right. So so there's a big difference between if you say the word like 250 and 52. Right? 52, 52, 52, 52, 250, 250. You hear how they sound a little bit different? That's S3, 250.
52.
S4 is 52.
Oh, it's closer together.
Oh.
52. 250 is
It's
S.
So I'm not saying normal. If you say,
The
like,
four
it's
is
really
close to
not
S1,
250,
but the S4 is yeah, it's
right.
Yeah, but
250,
AS3 is
52.
uh,
250, 52.
Usually fluid overload. But it can be normal.
it can be slower CTEP, right?
Can be, but it can be very, very fit people. Very fit people.
Yeah,
It means
yeah,
they have
yeah.
very
Athletes,
good
yeah.
hearts, right?
Not mine.
So it would be very. So we got that, right? 52, 52. Wait. Yeah, what? Yeah. Two fifty, right? 52, that was this. Okay. So S3 can be, heard normally, but it's usually not. I mean, they gotta be really fit. We're not just talking people who get the minimum exercise. So you should basically assume if you hear an S3 that it is problematic and it should be evaluated. More than just say, well, I guess you're fit enough, right? Because you'd hate to not be that fit or something like that. And it's always a trick if they say, wow, that's yeah, I go to the gym 30 minutes, 3 times a week. That's not that fit. I mean, it's okay. I give you credit, but it's not. S4, when you hear an S4 in that way, you should always think something more severe. And these are good times to do what next?
echo.
Cardiac echo, right?
Yeah, an echo.
You want to see what are you going to measure generally on the cardiac echo?
Function in the balls and stuff.
Are you going to see them move?
You're gonna see them. You're gonna see them.
Ejection
True.
also related to cardiac output, right? So ejection fraction is what?
Capacity, working capacity of how?
The amount of the heart. How much blood the
Kind
heart.
of, right? We're on that thing, but it's listed as a percentage, right?
Yeah.
It's percentage
How much
of the
blood
blood being
ejected out.
from, like the ventricle, for example, right? But so we don't expect 100%, correct?
No.
Some of it kind of residually stays in there,
No, exactly.
right? Right. What are normal numbers?
60, 70.
Right, so that's not bad. Normally it wouldn't say except 60s and 70s, but this is another case. This is something you should feel good about. Okay, so we talked about some of this, right? So I highlighted again, on inspiration you might hear the split on the aortic and pulmonic, on expiration you might not. So that's a good when we get to playing around with it. Listen, right, you shouldn't necessarily hear a split aortic and pulmonic. That would be problematic. And again, I understand that in the reality of this, these are kind of difficult to hear sometimes. You can hear maybe some obvious S3s and S4s. This is, again, if you have the right setting, you have the patient is the right thickness, right? Conducive, their thickness is conducive for listening, right? In their position, your stethoscope is good quality, right? And, you know, did I say not too much noise? And you take a moment to do it, and you have a moment to listen. So then you just gotta get in the rhythm of it and listen. Because there's a lot of distraction to it. You got, you have to tune your ear to it. You're not gonna just switch off from like having a conversation with this person and then suddenly go in there, okay, I got it. You have to kind of say, okay, what are we doing? Feel the pulse, which is diastole, which is systole. Let me just listen a little bit and see if I hear it. Definitely in the beginning, taking that extra time, you'll pick up more things. So we talked about this, right? So they make the difference between snaps and clicks, depending on whether it's opening or closing. We try to hear those as best we can. And if you hear anything that sounds like it, and over time you start to hear what kind of normal sounds like in your patients. So you want to kind of be reporting it. You may not definitively say this is what it is, but you're suggesting that this might be, and you may want to get it evaluated. So describing actually a murmur, right? We talk about timing. We know that has to do with systole or diastole, where it is in the whole cardiac cycle. We talk about the shape of it. What could the shape possibly mean?
Is it gradually getting louder or loud and getting softer?
Okay, so shape is really, yes, it has to do with that, but it's also the, it would be like a visual expression of the sound. We often see it drawn out. Crescendo is building up to something, and decrescendo is coming down. Location, so location has to do with listening to it, right? Which position you're in, second, third, fourth, or fifth. Do we notice the sound radiating in any particular direction? Like, could you hear it up in the carotids? Like, what valve might radiate up into the carotids? Why? Right, because then the carotids like a very near expression, right? Your brain gets kind of preferential blood treatments, right? So you should hear, that would make sense, right? So that's kind of when you hear radiation in those areas. And they'd be graded by intensity, 1 through 6, which is the first number that you might actually palpate it, you might actually feel it. Right, 4. So 1 through 3 and these are a little subjective, 1 through 3, so they're up to you to kind of determine what they are, but definitely 4 is A. All right. So pitch. What's the difference between a low pitch and a high pitch? Give me something in a low pitch. A sound.
I'm thinking this.
You're thinking,
this comes out
like a male voice, right? Instead of the lower pitch, low.
Yeah.
Right? When you're singing in the shower, you have to do low pitches, right? Now it's a low pitch, high pitch. You're trying to hit that Whitney Houston song or something, right? And then I feel that I'm stuck at that point, right? If I do any more, it'll just go bad. And now, so if you can break beyond that, that will be high pitch. So those are important to kind of be able to qualify which it is, right? And then we have some other qualities, right? Harsh, right? Musical. That's kind of like a little twinkly or something like that, right? Rumbling and blowing. So that would just be kind of practice. And you can see there's a little subjectivity between rumbling and blowing on there. So we talked about what are causes some of the murmurs, right? We know stenosis is a problem, right? We know problems with the valves themselves. They can be congenital, of course, right? Just changes in the heart there. Blood flow, causing increased amount of blood flow. So we know that there's a pediatric one, a murmur that we can often because of the blood flow issue, right? Or even blood thickening can cause a problem with that. Okay, so let's think through these, right? And we'll be practicing some of this as well too, right? So a mitral stenosis, tell me what's going on there. And where would you hear it?
The mitral valve
In the
can't
right,
fully open.
Okay, so let's start. What part of the cardiac cycle would occur? A stenosis, you would hear it.
When
No,
the,
stop.
when the atrium is contracting.
Let's think about it. So where is the mitral valve?
Between the
Left, left,
Between the left and the right,
left,
Left side, atrial, divides the atrium and the ventricle. So, in
midclavicular,
order to push through it, you have to have what contracting?
atrium,
Which is what phase?
diastole,
Diastole, so it's gonna be love or dub?
dub,
Dub. Right? Love dub, love dub, love dub. So you're gonna feel it, so will you feel a pulse at the time?
no.
No,
Shouldn't. Is
no,
kinda making sense?
no,
Little bit.
Pulse, you said pulse?
Would you feel a pulse?
no.
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 Did you only feel pulse in what phase?
Systole,
Systole. Okay, so where might you hear it best?
the left, fifth intercostal space,
Sorry,
midclavicular line.
Okay, fifth, right? Fifth. Yeah, there you go. So, okay, that's the place you want to do. So you would do it on diastole. Right?
When you don't hear the dub. Right?
You just hear the. You heard that?
No. When you don't hear the dub is when you hear it, right? Like the love dub, love dub.
Well, well, the dub won't be clear, is what you're
It won't be
saying.
clear.
Yes.
Yes, that's what I
Right, you
mean.
might hear love, love. That's what it might sound like that, right? Versus a systolic murmur would be dub,
Uh-huh.
dub, dub. I mean, rumble would be like, I don't know how you. What would a rumble sound like? Who's ready to rumble? Right. Okay, so let's think mitral regurgitation.
It's not closing all the way.
Mitral valve. Okay. So what phase of the cardiac cycle?
Systole.
Why?
The
Because of where the
ventricles,
blood is gonna be
ventricles
shooting
are
out.
gonna
So it's
contract.
coming right back.
Right. So yeah. Right. So blood is supposed to be flowing from the left ventricle out to the aorta,
Mm-hmm,
but if there's a mitral valve prolapse, for example,
mm-hmm.
right, meaning it's malformed and one part's hanging in, right, it doesn't close, so it comes
Back up.
And so this is one that, loudest in the apex.
Apex.
So we're almost like at the fifth there, right? But you can also maybe hear it in the axilla.
Mm.
Right? So why might you hear it up there?
It's because it's going back up.
Because it's coming back up, right? Yeah, it's coming back up. It would be like a reverse stenosis, the kind of sound on there, right?
So what would it sound like?
Well, they say harsh,
Oh, okay.
right? We're gonna listen to them, right? I don't think I could do harsh versus rumbling in mine, but we're gonna listen to them.
You're gonna put some to hear? To
What you wanna
listen?
do? You wanna do it? I have to see what slide I'm on. What's the slide I'm on?
27.
28 of 88? Jeez.
No, you could get there. Don't skip. Don't skip.
I'm not skipping. Yeah, how about, okay, and then this is that. No. I just study that, want to study this, want to study this, want to study that one. We have 3 sets of PowerPoints. Some of them we can do next week. We can listen to some of them. But let's go through them first. and then
Okay.
Let's see where we are, right? Jeez, I got 60 left. I was almost done. Awesome. Okay, common heart murmurs. Okay, same one. Aortic stenosis. Tell me about that. And I know if this is this is the same thing. I'm kind of going through this like this because this may be how it's helpful me to learn it, right? And then I felt like once I understood the flow, then I don't have to keep studying it so much. I just have to kind of refresh because now I say, okay, what flows where? What is it? But once I kind of get the flow of it all, it becomes a little easier just to be able to recognize it. Because first you have to go through this process, like where am I listening, right? Is it, even if you just go, where am I listening on the heart, where, you kind of know what valves reflect where, and which phase of the cardiac cycle is occurring on.
Mm-hmm.
And you got to feel, is this a regurg or a
Stenosis.
stenosis? So aortic stenosis, tell me about that.
The aortic valve's not opening all the way.
Okay, well, okay.
It's narrow.
So it's forcing
Narrow.
through a narrow one, maybe a calcified valve on what part of the cycle?
Ventricular systole.
System.
Okay? So it's a systolic murmur,
Mm-hmm.
right? So where are you gonna hear it?
Love.
Right? Okay.
Second.
Is this something you might hear up in the carotids?
It could radiate.
Yes.
Probably, right? Because you're gonna hear that sound echo, transmitting in that forward direction on there. Regurgitation?
It's not closing all the way.
Going back to the heart from
Going back?
Yep.
back into the ventricle.
Into the,
Guys, there are a lot of things going on. Okay, so it's diastolic, right? So we're here to regurgitate, right? So, right, because of where it is, right, as the diastolic, as you're pushing through the mitral, right, the other valve can close, right? Or if it doesn't close, a backflow occurs. So again, systolic murmurs, right? These are caused by stenosis, sclerosis. So this would be more like this is where you might hear one of the musical ones. Turbulent blood flow into the aorta. So remember, when we say aortic is these systolic ones, it also means that there would be pulmonic, could be heard in the same one systolically, right?
Mm-hmm.
So mitral regurgitation or prolapse could be a cause of that, right? So we also remember it could be a tricuspid as well. And we're gonna listen in different positions as well, too. And then we'll kind of know based on the position we hear it best. It is possible you may hear it in multiple positions, but you're gonna determine which position you hear it best. So obviously, if you have any defects in the septum between the atrium and ventricle, you may hear different sounds in there. So again, most important is that you are kind of able to determine, again, where the location is and what you think it is. It's not necessarily you're going to be diagnosing it, because nowadays we usually are going to just do the echo. And that will be a better diagnostic indicator. But you want to be able to have a source of referral. You hear it in the tricuspid area, it's probably this. So here's this one, right? You ever seen these Miss Ard and Mr. Ass?
yes.
Okay, so kind of helping you with this mnemonic to help you remember diastolic versus systolic. Remember when you see mitral, it could also be pulmonic, right? If you say, mitral could be tricuspid, and aortic could be pulmonic. So, we talk a little bit about this. Talk about describing those, but maybe this would be a good time to listen to some of them. So they can occur early, mid, or late, right? You would determine based on, you might actually hear the sound and then part of the murmur as well too, right? It could be pansystolic or something, pan-diastolic occurring across the whole thing, and you usually won't hear the love or the dub. And the same thing, and there's definitions of these, right? And the holosystolic will be occurring between the S1 and the S2. So this would be the shape, right? But these are obviously visual representations of this. Okay. This is kind of repeating, right? Everybody feeling like this is repeating? Yeah. So here breaks it up into what would be mid, late, or holosystolic. And there are very definitive reasons for why. I think it's not at this level very important to understand why something occurs mid or late. You're kind of still in that phase just to be able to recognize them and to be able to describe as best you can. It would be like dermatological lesions when we cover that stuff, right? The best thing you can do sometimes is, even if you can't fully diagnose this, is be able to describe it well. The description kind of makes a difference. It gives us a common language in the way we talk about things. So we talked about grading as well. It's got like pound marks all over the place. So you see a little bit where radiation occurs, right? We talked about the aortic stenosis occurring up in the carotids on there, right?
Mm-hmm.
Which is important to highlight, right? So they have pulmonic, right? That's why the second and third point, you might hear a pulmonic one. And the mitral valve one may even go a little further, right, than the actual position. It may go out more in that direction. So, yeah, when we have the S3, right, remember, let's make a sound with an S3, S1, S2, S3. What's the sound at?
250, and then
That would be a ventricular gallop.
252.
Okay, right? S4 would be an atrial gallop.
252.
Love that. And if you had all four, what would that sound like? Who has a spoon? Who can play the spoons? If it is, right, we're a band. Ooh, right, we'll call us, the Gallops or something like that, I actually think this one doesn't work. Okay. So when we're listening to them, we might do stuff listening with inspiration. We may have them squatting. We may have them leaning forward, right? So it's important. Well, how do we really should assess heart sounds?
Lying down,
Well, sitting. Usually we start sitting.
and then you can lie them down.
Lying down.
Left lateral.
Left lateral. The idea would be you're checking heart sounds in all of those positions, the same ones, right? 2, 2, 3, 4, 5. 2, 2, 3, 4, 5. Have you ever seen that done?
No.
Never.
Why? But I don't have to answer that question, right? That would be best practice, right? Because I didn't really want to do this, especially when you're left. You put the blood going that way, right? You're going to exacerbate some murmurs, right? You may have them moving forward on there. But that would be the ideal, and that is the testable way to do it, right? That's how you should be doing it. So you might just do when they lie down, right? You do the abdominal sounds, and then you listen laying down, right? You ask them to roll to their left. Maybe you do like a combo prostate exam and heart sound check. Something like that, right? And that will be the hardest thing to do in an exam is get people to get their prostate checked, these guys. They really got issues with it, a lot of them, right? I could care less. Myself, doing it and getting it doesn't matter, it's like, who cares? Okay. So we're going a little bit here into hypertrophic cardiomyopathy. This is one where you can have sudden death based on this, right? This might be suggestive of this. This is perfectly helpful, like athletes, and they're running down the court and they just fall over. Because they usually have a congenital problem that's going on there. Let's see where we are. Okay. Let's see if you want to listen to a few heart sounds? Just to give us like our initial. Anybody not want to listen to heart sounds? Anybody want to go home or something? Or? Yeah. We'll just do a few heart sounds and we'll take a break. You're feeling this, but I think this is the fun part of it. So we're, I have some there logins. So you'll go to modules. This is the one I liked. I think it's in reading. No, it's not in reading. Resources. Bad section is in it. I think this one was pretty good. Last one. Okay. If you really want to get into this, you can kind of just like close your eyes and guess it. I mean, because you're going to see what I can turn it off. What?
I already saw it.
Is that an issue that happens sometimes? I don't think so. It has a display on and off. Oh, forget it. I don't want to mess with it. So you got me nervous about that, right? I mean, that's how you treat it. Let's see if that sounds. Do I have an audio?
Why don't you just minimize the window if you don't want us to see it?
But I can't click it. I don't know what the heck's playing. Right?
It's okay, we don't really know much.
You don't know much. I know you know how to read. If I could dim it or something.
That's it? That's one right here?
This is normal.
I think the drums. That means we're going to war.
That's three?
That's what I think. Tribes are coming. Run. Okay, does that kind of feel like S1, S2?
Yeah.
That if you're not in a fully developed country, this means run. Pack your bags, get on the first plane, out. Okay, we're gonna listen to ones we might hear. So let's do a systolic murmur. Let's forget what they are. Let's just say that we're just trying to see if we can tune our ear to it. So we know what it is. So we have the advantage of trying to tune our ear to it, right? It's kind of going S1 and
You
then
hear it kind of the
I don't hear it S2 clearly.
Because remember, occurs in the first,
Yeah.
in the first sentence.
I hear it.
Let's see if we are mid systolic.
Yeah, I think it's in the middle. Oh, that one's really in the middle. That one's in the middle.
So, that's,
It says mitral regurg.
what is that?
Say it's mitral regurg, but mid systolic. Outside of what it is, let's just try to see if we
Fall
can.
asleep.
It's like,
Because you hear the S1 clearly.
Que sueño.
Okay.
Que
Let's see
sueño.
hollow systolic, how it's different.
Que sueño. Que sueño.
What's that one?
it's the same thing as mitral regurg.
That's a hollow systolic.
But it's like through
It
the
occurs
whole,
all through systole.
through the whole time, yeah.
So you see, it's a little challenging, right? You really gotta kind of tune your ears to it.
Very
Let's go.
challenging.
Can you define hollow systolic again?
It would be occurring between S1 and S2
Like the whole time?
the whole time.
Yeah.
Because you can hear it there, the sound goes all the way through. Let's go back to normal, get our ear back to this.
Which is hollow systolic, right?
The hollow systolic just means that it occurs during the systole the whole time.
If we were anthropologists, we'd be deciphering the meaning of
This
these
is
drum
the
sounds.
Left eye.
Okay, let's do S3. Not as good as ours, I think.
No, it's not.
Ours is better. Let's see if it's S4.
Sounds almost the same.
Sounds like they're not so good at this one.
That sounds almost the same. It's like right before one.
Yeah. PS4.
It's just like awful. I'm like,
Let's see if we can do a split S2. You can hear that. That one's pretty good. You hear the second one's a little like kind of staggered, a little longer.
yeah, like it stays a little.
Yeah.
Oh my
You want to hear what a diastolic murmur?
God. Sure.
This might be aortic regurgency. There, you see, it's very the whooshing is very light.
Aortic regurg.
Kind of hear a lub dub and little whoosh after. Not as exaggerated as the other ones, but it's lighter. So again, when you start listening to these, you really want you to do in like either, put your hands on the radial pulse at the same time, right? So you can really first just get which part of the
Identify which
cycle.
one in the system.
Yeah. And then just start to, but you can see this is not so, you can't be chit-chatting at lunch and then coming in and then suddenly your ear attunes to this instantly. It is really like you gotta be listening and listening, because you can't really slow the tape down, right? When you're doing with a patient. So you can't, there's no way to do that. You have to really say, where is that kind of whoosh occurring, right?
So like 10 beats of it?
So, I think that was kind of a general, feel for all these, but this link is on there as well too.
No.
So again, the systolic ones are going to be occurring like either over S1 or right after the sound of S1, in between S2, and the diastolic will be occurring after S2, in between S2 and S1.
Mm-hmm.
So, and then it depends on really position. Then you start to say, okay, this is this, diastolic, systolic, where am I hearing a murmur? What position am I at? It's probably a mitral regurgitation. Right? Where I suspect. Okay, let's take a break. What do you want, how long do you want to break?
How long do we have left?
Hours.
I don't know, wanna take 10 minutes?
Yeah.
Is that enough?